Thank you, Mr. Chairman. Good morning, everyone. My name is Mohammad Sharkawi. I'm currently the head of the orthopedic department of Asyut University, Egypt. I'm here today for the first time joining this conference, although I have been invited in every conference before, but I could not make it. It's a great pleasure to be here among colleagues and dear friends from Qana and South Valley University. Thank you, Dr. Said Al-Hamid, Dr. Hamdi Tamam, and all friends for inviting me. So my presentation today is about the treatment strategies of the ossification of the posterior longitudinal ligament. Back during my early career and studying in the medical school, we were told that this pathology is rare in our region and our country. However, with the advancement of the imaging techniques and, I don't know, changes in the weather, food habits, we see this pathology more frequent than what we expected or what we were told many years ago. So I felt it's good that we discuss this and make sure at least that we do not confuse patients who present with cervical myelopathy due to ossification of the posterior longitudinal ligament with those with other degenerative conditions like cervical disc protrusions or cervical canal stenosis, because the treatment is different, as well as the prognosis as well. So we all know the posterior longitudinal ligament, the normal thickness is between 1 to 2 millimeters, and it extends from the base of the clivus to the sacrum. And the ossification of the posterior longitudinal ligament is just an ectopic intramembranous ossification of this ligament that causes gradual and progressive compressive myelopathy. We do not really, and no one really knows the etiology of this. It's probably multifactorial. The incidence is about 4% of asymptomatic older people, and it is commoner in the cervical spine. However, it can present in the thoracic and in the lumbar spine, as you can see in this example. We have to remember that it is a progressive condition. So whatever we do for our patients, we have to tell them that there is a possibility that it continues to progress and that they may need another treatment or surgery. So again, in this example, you see how it progressed with time. Well, people who deal with this pathology more frequently know there are a classification. There are several types, like a continuous type or a segmental one from one segment to the other, or a mixed type that combines between them, and there is a rare localized type. And these are examples of all the presenting images for this condition. We rarely can see this in the plain X-ray. This needs a very high index of suspicion, especially with the quality of the plain X-rays we get nowadays. But the CT is the one imaging of choice to diagnose this and differentiate it from other degenerative conditions and cervical disc protrusions. I just want to highlight this particular sign. This is a double dura or a double ligament sign, and it means that the anterior dura is ossified, and there is probably also intradural penetration of this ossification. This makes the treatment more challenging. Patients usually present with progressive myelopathy. The MRI, although can confuse us, but it is not the it's not really diagnostic, but help us to see if there is a cord compression, the degree of the canal compromise, and we can measure the diameter of the canal and make sure that we know the extent of the lesions. Patients early on present with unspecific complaints, but later on they have increasing neck pain and stiffness, severe numbness and tingling in the hands and lower limbs, myelopathic signs, and sometimes also radiculopathy. How do we treat them? Well, conservative treatment like color, medications, physical therapy, lifestyle adjustments, they are not adequate. They are not treatment, but they are supportive measures, can use temporarily in the very early cases. But as I said, the disease is progressive, so we need to follow up these patients, and whenever we find significant myelopathic symptoms, it is the time for surgery. What type of surgery do we have? We have several options, either anterior cervical discectomy, anterior cervical corpectomy with certain limitations that I'm going to describe to you, laminectomy, laminectomy infusion, and laminoplasty. How do we choose between anterior surgery and posterior surgery, and what's the advantage of each? So this is an anterior pathology, and we were told that when the pathology is anterior, you have to go anterior. So this is anterior surgery affords a direct compression, ability to restore the cervical lordosis. It's suitable particularly for patients with kyphotic cervical spine. However, because of the ossification of the ligament and the adherence to the dura that might also be ossified, there is a very high incidence of dural tears, CSF leak, and postoperative dysphagia. And there is also a possibility of C5 palsy and postoperative neck stiffness. On the other hand, the posterior surgery affords, in most cases, adequate indirect decompression. It maintains the cervical lordosis. However, this is associated with a higher incidence of C5 palsy, epidural hematoma, and infection. And there are many reports of postoperative axial neck pain, although this is not my personal experience. How to choose? Now, the modified K-line is one of the measures that we use to decide on anterior or posterior. This is an imaginary line from the midpoint of the C2 to the C7 canal. And if the ossification of the posterior longitudinal ligament passes beyond this line, we call it K-line negative. And this is an indication that posterior surgery might not be adequate. So if we have a K-line negative, this might encourage us to choose the more difficult option of anterior surgery. If the ossification of the posterior longitudinal ligament does not pass behind this imaginary line, we call it K-line positive, and this is an indication for posterior surgery. Again, this picture shows you the K-line positive and negative one. So can we do laminectomy? Well, laminectomy is the easiest posterior surgery. It's simple, it's effective, it's very cost effective. There is a danger of developing a post-laminectomy scar and kyphosis. And as I mentioned, because this is a progressive disease, the ossification of the posterior longitudinal ligament may progress and may need further decompression. How about laminectomy infusion? This is more or less the standard technique that we use. And although it is more complex and more costly, but it is very effective, particularly in cases with K-line positive. There is a less incidence of the ossification of the posterior longitudinal ligament because you stabilize the spine. So this minimizes the triggers or the stimulus for the progression of the ossification. However, of course, this results in neck stiffness. This is a case that was, excuse me. So this is a case that mandates, it's really challenging with 2 pointers. Because the ossification of the posterior longitudinal ligament extends beyond the C2, so this needs if you do laminectomy to remove the C2 lamina, and this definitely will lead to post-operative kyphosis. So in a case like this, you have to do, give me one more minute, please. You need to do fusion. How about laminoplasty? We have several options of laminoplasty. What I want to share with you is part of our experience in Asyut University. So this is a case that we treated in Asyut. This is the standard option to fix the lamina after doing laminoplasty. This is not available in this country and it's very expensive. So that's why, with the help of Dr. Mohammad Khalid, who's doing his MD thesis in our university, under my supervision, we have developed a technique using the mini plates of the small bones in the hands and fingers. And so far, the results are really good and the expenses are really affordable to our patients. I'm going to share with you a case that he operated himself alone. So as you can see here, the pre-operative and the immediate post-operative and the follow-up MRI, follow-up CT, showing how the canal was widened. And here the other levels at the follow-up after 1 year. And this is the MRI, the pre-operative and the follow-up MRI showing adequate maintained decompression of the whole cervical canal. So I just want to make sure that you know that this is the work of Dr. Mohammad Khalid, and I want to thank him. He's a very dedicated colleague that we are really happy to have him with us in Asyut. And this is our patient with 1 year follow-up. So laminoplasty, as you can see, maintains the mobility of the neck. And we just need to keep our fingers crossed that the ossification do not progress further. How about the anterior surgical options? We usually do this in very limited cases, and خلي بالك السبيكر الثاني مش موجود يعني فما تناقش عليا قوي كده. So this is a case that was treated many years ago in our university as well, together with my professor, Professor Assam Sharif. And of course, you know, dural tear occurred, CSF leak occurred, but this is usually self-limiting and the patient did very well afterwards. Sometimes actually we need to do combined surgeries. And in this case, in my belief, we should start by the posterior surgery because this will be safer. And you can do MRI like 2 or 3 months post-operatively to make sure that the patient really needs another surgery anteriorly in case he does not recover completely. What's the expected outcome? More than 60% mean recovery in the modified Japanese Orthopedic Association score. The neurological functions improve, the symptoms greatly improves, and the quality of life. However, there are usually residual symptoms, and we have to remember the complication risk. So the take-home message is that the success of the surgery for the ossification of the posterior longitudinal ligament depends on the extent of the ossification, degree and duration of the myelopathy, the patient's overall health, and specific surgical technique used. It's important to discuss all this with the patient and to set realistic expectations because recovery is never 100%. Thank you very much for your attention.